At ESC 2013, we were talking about the TASTE trial and the failure of thrombus aspiration. Now, that left a bad taste in a lot of people's mouth because they were questioning the data in a number of different ways. Well, now here we are at the 2014 ESC meeting in Barcelona, and we're talking about a paper in the September 16th issue of JACC, and it is looking at thrombus aspiration in NSTEMI, and it is the TATORT NSTEMI trial, and I'm with Holger Thiele, MD, University Hospital at University of Lübeck in Germany. First off, it is pronounced TATORT, right?
Yes, it's
What is TATORT?
So this is it's an acronym for sure. But we use this acronym because this is a German crime scene. So everybody, not everybody, but so many people in Germany are watching it on every Sunday. So at 8 o'clock on Sunday, people are sitting in front of the TV and they're watching TATORT. So which is a German crime scene, which is very famous.
They're watching your clinical trial.
Yeah, maybe. But this is the reason why we use this acronym for this trial. Yeah?
Now, you originally presented data at TCT, correct? Was it last year?
Yeah, it was last year, yes.
All right. So we've talked about this before, but now the paper is coming out in JACC. So let's go back. Let's talk about NSTEMI, and let's talk about the TATORT NSTEMI trial. Why did you do the trial in the first place?
So we did the trial because there were no data at all for non-STEMI patients for aspiration thrombectomy. So we had the data from for STEMI patients. So at least many of the trials were positive with respect to surrogate endpoints, and this was also the reason why we decided to go for such a trial, assessing if thrombectomy will reduce microvascular obstruction or no reflow in patients with non-ST elevation myocardial infarction. This was the hypothesis what we had.
So how many patients did you look at and what did you find?
So we looked for 460 patients altogether, which were randomized to either standard PCI or aspiration thrombectomy plus standard PCI. This is what we did. Maybe important in comparison to many other trials in STEMI patients, we only included patients with visible thrombus. We used the TIMI classification, and so they had to have a thrombus, which is probably important, and which is also different from STEMI trials, where usually it was just randomized, not based on thrombus. Right. And then the primary study endpoint was microvascular obstruction, which we measured by cardiac MRI in these patients. So it's a surrogate endpoint, this is what we were looking for. And unfortunately, this is what, against our hypothesis, we could not find a reduction in microvascular obstruction in the aspiration thrombectomy group. So it was absolutely similar in comparison to the standard PCI group.
Do you really think it's time that we start to rethink this whole concept of thrombus removal if it just doesn't seem to be working time and time again between TASTE and now TATORT and STEMI?
Yeah, difficult question. So at least we were able to extract thrombus in the majority of patients by aspiration. So there was a visible thrombus, and this also led to a significant higher rate of primary stenting in the aspiration thrombectomy group because the stenosis was much more better visible. So the operators decided to go for primary stenting in comparison to PCI with a balloon and afterwards stenting, but nevertheless we were not able to show any reduction in microvascular obstruction. And this is also supported by many other secondary endpoints. We were looking for myocardial blush grade or perfusion grade. We were looking for TIMI flow, and we also were looking for enzymatic infarct size. We could not show any benefit.
I mean, given the study that you've conducted, what do you do now when you see thrombus? Do you aspirate?
Good question. So in particular for non-STEMI patients, we currently do not aspirate. But I think for STEMI patients, if you have a huge amount of thrombus, I still consider it, in particular for patients with right coronary artery, where we have massive thrombus, then I still do it there. We will have to wait for, in particular for STEMI, we have to wait for the long-term results of the TASTE trial. We also have to look for the long-term result, or for the results of the total trial, which is currently ongoing. So I think we should not close the books at this time.
Right. I mean, we talked to Dr. Jolly last year at the ESC meeting, and he's working on the total trial. So,
yeah, sure, I know.
You know,
but they had to increase the number of patients, which was also based on, so I think they even more than doubled the number of patients to be included in total, based on the low event rate. And so this is the reason why they increased it. So we will have to wait until we have these results, and then maybe we have to discuss it once again.
Well, you can come back anytime. This happens to be the September 16th issue of JACC. If you want to go find out more about the TATORT and STEMI trial, that is the place for Cardinal Source World News. I'm Executive Editor Rick McGuire.